Okay, good afternoon everyone. Just would like to welcome everyone to this final session of the day, which is the patient presenting with. My name is Wendy Gamlin and I am the non-invasive lead at Manchester Royal Infirmary. I'm co-chairing today with Emma Rees.
Hello, I'm Emma Rees. I'm Associate Prof of Healthcare Science at Swansea University. And I'm going to introduce our first speaker for you this afternoon. Dr. Anjana Siva is consultant cardiologist and head of echo at Portsmouth Hospital NHS Trust, and she's going to talk to us about the patient with dyspnea.
Thank you very much. So once again, thank you for inviting me, and it's lovely to see all of you face to face. I'm going to talk about the patient presenting with dyspnea, or the breathless patient. So breathlessness is a really wide diagnosis. It's got a huge number of differentials which you need to be aware of. Otherwise, the whole history examination thing becomes very complex. So you need to understand that as well as the cardiac and respiratory causes that might cause breathlessness, there are a number of hormonal, metabolic, toxic, physiological, and even neuromuscular causes of breathlessness. The neuromuscular ones are actually particularly tricky because you wouldn't even consider those in the cardiac environment, but weakness of the muscles of the chest wall and the diaphragm are actually the cause of breathlessness being a common problem in patients with these diseases. So what causes the actual dyspnea? So we're looking now here mainly at the cardiorespiratory causes. So when you have a lesion on the left side of the heart, you can get back pressure extending up to the pulmonary arterioles, which causes extravasation of fluid into the alveoli and pulmonary edema. So that's one cause, whereby left-sided heart lesions can cause breathlessness. However, just having poor left or right ventricular systolic function with the low cardiac output reduces blood flow to your peripheral muscles and gives you this other symptom of fatigue. And fatigue or tiredness is often associated in patients' minds also with breathlessness. So it can be the forward flow problem as well that causes this concept of feeling breathless. A primary lung problem obviously will cause breathlessness by damaging the interchange between oxygen and the blood in the lungs by a number of mechanisms. But our echo can be helpful there because obviously if it's been severe and long-standing, it will cause back pressure to the right side of the heart and you'll have a dilated right heart, maybe elevated pulmonary pressures and possibly evidence of peripheral high volume and pressure with your dilated IVC, etc. So right-sided failure can be caused by lung disease, cor pulmonale, or left heart disease, congestive cardiac failure. So it's already closely interlinked, the symptom of breathlessness and changes that you'll see on your echo. So cardiac causes of breathlessness, these are all going to be much more familiar to you. Left ventricular systolic or diastolic dysfunction, pretty much any valve disease, ischemic heart disease, especially in diabetics who don't often get chest pain, where in the same way as non-diabetics, they may present with breathlessness as an angina surrogate. Pericardial constriction or fluid tamponade, myocardial restriction, tachyarrhythmias, e.g. fast AF or flutter, and an intracardiac shunt. So tachyarrhythmias cause breathlessness by causing the heart to be very inefficient. The very short diastolic interval means that cardiac filling is reduced and therefore, again, back pressure to the lungs and beyond. And if it's chronic, you will eventually get left ventricular failure or tachycardia-induced cardiomyopathy. Similarly, restriction causes the heart to be contained in a box which doesn't stretch and therefore you get reduced filling. And an intracardiac shunt initially will cause volume overload of the right heart as the shunt goes left to right. But if chronic and left for years, you would eventually get high pressures on the right side due to damage of the pulmonary arteriolar system and may eventually get reversal of the shunt. So all of these conditions can cause breathlessness and changes on your echo. Respiratory causes of breathlessness. So we often see a crossover between respiratory patients being referred to cardiology clinic and obviously our respiratory colleagues see vice versa, so it's important to be aware. So respiratory disease can cause destruction of the alveoli, for example, COPD or fibrosis, can cause obstruction and lung collapse, for example, carcinoma of the lung, and obviously collapse with pneumothorax, and also you can get obstruction of the blood supply to the lungs, as in pulmonary emboli or chronic thromboembolic disease. So the chest X-ray top left is one that shows pulmonary fibrosis, this coarse network of fibres. The one on the right is a pleural effusion, I'm sure you can see that, and the lower pictures, the VQ scan in the middle shows lovely ventilation, smooth outline of the lungs in the top two images, and this patchy defects of perfusion. And the CT scan on the lower right shows truncation of the pulmonary arteries. I've got a pointer here. There you go, they stop dead. You've also got a defect here where you've got an obstruction, and here, and this is chronic thromboembolic pulmonary disease. Usually these people don't present with PEs, they present with breathlessness. Really important to pick up on that. That's what the VQ looks like. These people are curable, and without the right treatment, they do very badly indeed. And a picture here is of someone with a poor right ventricle, very tachycardic, I hope you can see. This person's just had a PE. Right, put some echoes in just to make it a bit more interesting. So, taking your history, really important to take a detailed history because the cause of the breathlessness can come from anywhere. And it's also important to know your patient, to understand the context in which your echo sits. So ask how severe it is, and we use this classification, you've all heard of it, I'm sure, the New York Heart Association, 1 being the least severe, normal functional status, and 4 being the most severe, severe breathlessness at rest. Ask what makes it worse. Is it worse if they lie flat, as in pulmonary edema? Also, COPD patients don't like lying flat, they also prefer sitting up. Associated features, do they have a cough? Do they cough anything up? Do they get chest pain? Is it cardiac? Is it tight on exertion? Or is it pleuritic, sharp and worse on inspiration? Do they get lightheaded, suggesting low blood pressure? Do they get palpitations? We want to know anything of note in the past, cardiac or respiratory conditions that they may have had previously, any operations, etc. Ask about other systems. Remember, anemia causes breathlessness. Thyrotoxicosis causes tachycardia. So you want to know, is there anything else wrong with any other part of them? And social. Smoking, of course, no-brainer with lung disease and ischemic heart disease. Alcohol causes a cardiomyopathy. You want to know about their social situation. How fit are they? How frail are they? All of this will impact on your decision-making later down the line. So then we examine them. Always start with observation. It tells you, is this person acutely sick? Are we in trouble here? So are they sitting up upright, holding themselves, bracing themselves like they do in severe COPD? Are they tachypneic? Normal respiratory rate is 12 to 16 breaths. Can they complete a sentence without having to take a breath? That's a sign of breathlessness. We should be able to speak, except for when we're presenting, without breathing in within a sentence. So I'm tachypneic and obviously not very well. Central cyanosis, blueness around the lips, a sign of CO2 retention in COPD. And their skin colour, is it pale or is it that waxy sort of grey colour of cardiac failure? Then we examine. This is just a brief, and I'll go into a little bit more detail. Feel the pulse. Is it regular? Is it fast? Check the blood pressure. Is it low? Sign of potential nastiness. JVP, always have your patient in the right position, 45 degrees with the neck supported. Check the precordium for the apex beat and the other bits that you feel in the precordium, which I'll talk to you about. Listen to the heart, listen to the lungs, and check for edema. Okay, the pulse. We start usually at the wrist. The wrist is helpful for timing the pulse, but not always. In fast AF, the variability, beat-to-beat variability, means that in the very close together beats, you've got barely any cardiac filling, and therefore that pulse is often so weak you don't feel it at the wrist. So the accurate assessment of heart rate in fast AF is with a stethoscope on the heart, okay? You'll often underestimate the heart rate in fast AF. A sinus tachycardia is often a sign of pathology, or the fact that you've terrified your patient, or the fact that the lifts aren't working. So, bear all that in mind. If you want to know about the character of the pulse, don't bother with the wrist, usually. Feel at the carotids. Now, the carotid pulse is hard to feel. No one walks in and does it beautifully, so practice. Practice on yourself, practice on your friends. Remember, one side at a time, though. Okay? Right. Blood pressure. Now, blood pressure is an extension. In fact, I should say the pulse is an extension of the blood pressure. So your blood pressure will follow on from what you've identified on the pulse. So if they are hypotensive, so systolic blood pressure less than 100, you'll probably find the pulse at the wrist is quite weak. A narrow pulse pressure, so the normal pulse pressure is about 40 millimetres of mercury, so 120 over 80, it's a normal pulse pressure. If it's very narrow, and especially if it's accompanied by a lowish blood pressure, it's a sign of significant aortic stenosis in some cases. If, however, you feel at the neck and it's a slow rising pulse, that's a really powerful sign of aortic stenosis. Sorry, that's a pulse bit of information in the blood pressure section. A wide pulse pressure might be a sign of aortic regurgitation. It is not the only thing, but this is all about gathering snippets of information to then use when you assess the heart with the echo. Well, that one didn't work. Oh, that was a lovely picture of a really stenosed aortic valve. Anyway, the JVP, this is the bit that most people really hate because it's a very medic-y thing, okay? So the key thing here is you've got to get the patient in the right position, otherwise you might as well not bother. So you have to tip the bed so they're at 45 degrees and you have to put a pillow behind their head so the skin isn't all stretched and so that this muscle, the sternocleidomastoid, is relaxed. You then slightly tilt their chin away so that the jaw isn't casting a shadow over the neck. Do not get them to look to the left because your patient's going to want to help you and they will look so far to the left that the skin will be like a drum, okay? Slight tilt to the left. Have a little look along this line. This is the external jugular. Ignore that. It's often obstructed because it gets obstructed by superficial factors down here. So medial to the sternocleidomastoid is where you look. And that is also where the carotid pulse is felt. So you might see, if they've got a vigorous carotid pulse, you might actually be looking at the carotid pulse. And the way you differentiate is that, one, you can't feel the JVP. You can feel the carotid pulse. So if there's a really pounding, palpable pulse there, chances are you're looking at the carotid and not looking at the JVP. And the other thing is, the JVP isn't a single pulse like the carotid, it's a double pulse. The first corresponds to atrial activity, and you'll feel that in diastole. And the second, or you'll see it, you can't feel it, you'll see it in diastole. And the second corresponds to systole, and you'll see it when your pulse is working. So whenever you're looking at the JVP, your hands aren't flapping uselessly by your side. One of them is feeling the pulse, the arterial pulse, either at the wrist, at the brachial point, or even a really lovely place is just hooking your fingers behind the clavicle and you can feel the pulse of the subclavian artery there. It's quite a comfortable place for the patient as well. And then you look for this double pulsation. If they've got tricuspid regurgitation, you'll get a huge V wave that will coincide with systole. If they've got just heart failure and elevated SVC pressures, the whole double pulse will rise. If they've got complete heart block, which you should have picked up on the pulse rate, they'll get cannon A waves where you get the intermittent massive A wave as the atria contracts against a closed tricuspid. Either way, if they haven't got any of that and everything is fine, you will not see the JVP. It shouldn't be visible at all above the clavicle. Precordial examination. So you need to understand where things are supposed to be. The apex beat, which is supposed to be at the fourth intercostal space mid-clavicular line, it may not be. So the way you feel for it is you start right into the apex, you feel firmly, go through the fat, feel on the chest wall with the pads of your fingers and come medially and upwards till you feel the pulsation of the apex. If it's in the fourth intercostal space mid-clavicular line, chances are the heart left ventricle is normal size. If it's displaced down and laterally, chances are it's dilated. The lower left sternal edge, fourth intercostal space, is the tricuspid area. Sorry, the apex beat is the mitral area. This is the tricuspid area. This is where you will hear tricuspid regurgitation, but when you're palpating, the palm of your hand placed firmly over here, you might feel a right ventricular heave in patients with elevated right-sided pressures. The aortic area sits to the right of the sternum in the second intercostal space. This is where you will hear aortic stenosis at its loudest. So these are the places where, when you feel the precordium, it really is mainly the apex beat and the right parasternal edge that will give you the information. Heart sounds. This is hard. So if you're serious about getting any good at this, get a stethoscope, have it with you always, and use it. When you're doing echo, if you see someone with significant mitral regurg, produce your stethoscope and have a quick listen. It takes moments. You will learn really fast the difference between mitral regurg, pansystolic murmur, aortic stenosis, ejection systolic murmur. You are in the best position ever to learn to get good at listening at the heart. Far easier for you than it is for medical students who have to stumble around the wards hoping they can work out what's wrong with someone's heart. You know already when you've done an echo. So, apex beat, mitral area. You'll get a pansystolic murmur of mitral regurgitation or a soft, hard to hear, diastolic murmur of mitral stenosis. You might hear a third heart sound of left ventricular failure. If you take your stethoscope round with you onto CCU when you do ward-based echoes, that's the best place to listen for that. Right parasternal edge is where you'll have the tricuspid area, so pansystolic murmur of tricuspid regurg, or you might, bizarrely, hear aortic regurg better here. Unfortunately, this murmur breaks all the rules. The aortic area is where you hear the ejection systolic murmur of aortic stenosis. Left-sided heart murmurs are louder in expiration, right-sided murmurs are louder in inspiration. So the best thing to do is to listen at the precordium in the areas with the patient sitting back where you left them when you looked at the JVP, and then at the end, sit them forward, listen at the lower left sternal edge for your aortic regurg in expiration. That will be the end of your auscultation. It's a nice smooth way to do it because then they're sat forward and ready for you to listen. None of these are working. That was lovely tricuspid regurg and that was aortic stenosis again. Anyway, so then sit them forward and you listen to the lung bases. So you've already sat them forward to listen to the aortic regurg, and then you listen to the lung bases with them breathing in and out through their mouth. They breathe in and out through their nose, you get a lot of sound from the narrower passages that gets in the way. Listen at the bases for fine end expiratory crackles in pulmonary edema. Again, when you're on CCU, this is where you will hear loads of this. Pulmonary fibrosis is different. It's coarse, much louder, and if you ever do echoes up on the respiratory ward, your stethoscope will come in handy for hearing that. Pleural effusion, no breath sound at all, usually on one side, might be on both. Also, asthma will give you an expiratory wheeze, high-pitched wheeze. Not a hope of that working either. That was a impaired LV with the speckling due to amyloid. Good. Peripheral edema. Your patient is now sitting forward. Start with edema at the sacrum. If they've got severe edema, it will come right up to the sacrum. The way you test for that is you always press, ideally if you can, over a bony prominence for 10 seconds, usually with the pad of your thumb. Don't use a fingertip, it's too pokey, and warn the patient you're going to do it, okay? Press for 10 seconds, release, and if there's a dent left, that is pitting edema due to fluid. So you do that over the sacrum, and then you move, let your patient sit back, cover up their chest, move to the ankles, press over the medial malleolus. This is often tender. Warn your patient. If it's sore, let me know. If you've got edema there, work up your leg over the bony tibia and then beyond, doing the same thing until you reach the top extent of the edema. And the higher it goes, the worse it is. This is a dilated IVC. It's probably not going to play. It's not collapsing. And you will see this on your echo in someone with severe peripheral edema. If you've got a beautiful IVC that's collapsing away, then you've got to ask yourself, was that peripheral edema? If it doesn't pit, it might be lymphedema. And if it's only on one leg, it might be venous insufficiency and not actually to do with the heart. So this dilated fixed IVC will go with peripheral edema. Other causes, tamponade. So if fluid builds up in the pericardial space, so much so that it causes pressure within that space and restricts right ventricular filling, you get tamponade. If it builds up really fast, only a small amount of fluid is needed and your patient's in trouble. If it builds up slowly and the pericardium's had time to stretch, you might have a massive effusion. But either way, clinically, you get Beck's triad, amongst other things. Patients hypotensive, they've often got distended jugular veins and muffled heart sounds. They also are likely to have a pulsus paradoxus, which is an exaggeration of the usual, so your normal blood pressure will drop a little bit on inspiration. Because you're breathing in, there's a slight preferential for right ventricular filling, slight reduction in left, and you end up getting a slight drop in systolic blood pressure. But in this situation, because this is a box, when you breathe in and you get more blood coming into the right side, it directly impedes on the left, causing a big drop in output on inspiration of greater than 20 millimetres of mercury. That's important. And that's reflected on your echo when you look at mitral inflow in these patients. So always look at that in the 2-chamber view. If you do it in the 4-chamber, the heart swings a lot from side to side, makes it less accurate. So 2-chamber view, PW on mitral inflow, and what you get is this variation with respiration. Put your respiratory trace on, and at the beginning of inspiration, you get a big drop of at least 25%, and that is the echo equivalent of your pulsus paradoxus. And also your patient will be tachycardic if they've got a tamponade. Tachycardia is always a very helpful sign. Other causes of breathlessness, pericardial constriction. Again, heart's encased in a box. This time it's the pericardium that's thickened and constricted. Tends to develop very slowly over time. They may have this sign, Kussmaul's sign. The JVP should drop in inspiration. We never usually see it, so we don't usually check it, but should drop because your right ventricle fills as you breathe in, which allows the SVC pressure to drop a little bit. In constriction, it doesn't drop. It may stay the same or it may rise, and that's Kussmaul's sign. These people also get the pulsus paradoxus because there's that competitive filling with inspiration. You might hear a pericardial knock. I've never heard a pericardial knock, but if anyone's going to hear it, it will be you guys, because you know when they've got constriction. And these guys, because it's been building up very slowly, they've often had time to develop quite a lot of peripheral edema. Peripheral edema in acute tamponade doesn't tend to be a thing. They develop the acute hemodynamic effect of compressing the RV way before they've had a chance to get peripheral edema. If they've got tamponade and peripheral edema, it usually means that's been building up slowly. And here we go. This is the other echo sign that is the equivalent of pulsus paradoxus. This is the aortic arch, PW flow, and again at the start of inspiration you get a big drop in aortic flow. This is echo equivalent of pulsus paradoxus. This was also going to show you the pericardial shudder, which occurs when you've got interdependent filling of the right and the left ventricle, and that was going to show you that even more closely. I'm hoping that on the online version of this talk they'll get this working. And this is to show you, not very clearly, and that's deliberate, that the echo is not the best modality to look for pericardial thickening. It does show a bright and thickened pericardium, but do not think that because you can't see it, it's not restriction. Much better modality is CT or MRI. So why bother doing all this? I mean, why not just do the echo, write the report, and send your patient off to whoever? It's because anything that you discover relating to the examination that's out of the ordinary will add to our decision making, and it will add to your report. So the presence of heart failure or overload indicates the need for urgent action. A breathless patient with severe mitral regurgitation and peripheral edema needs a registrar to come and prescribe some diuretics, may even need admitting, certainly needs that mitral regurgitation addressing urgently. Patient symptoms will also lead to early surgery, maybe when your echo doesn't even suggest it. So if you get a moderately regurgitant mitral valve that's easily repairable in a patient with symptoms, we're much more likely to refer them for urgent surgery. Similarly, if you've got a very breathless patient with only moderate aortic stenosis, we also might refer them because they might be one of that small cohort that's the high-risk moderate aortic stenosis cohort. We'll certainly send them off for a treadmill test and we'll be working on them quite closely. A lack of symptoms is hugely important because if you find severe mitral regurg in a totally asymptomatic patient, I'll probably observe them, won't rush around, referring them for surgery. On the other hand, if they're asymptomatic and they've got severe aortic stenosis, I want to know for certain, are they asymptomatic or are they just doing so little they're not actually getting breathless? I might put them on a gentle treadmill or even walk them down the corridor and check them out a bit more closely. Their social situation is important. What do they do at home? What's their quality of life? Are they a carer for someone else? All of this is going to influence what I do when I see your echo report. So it's hugely important. So the ultimate aim of all of this is to have fully patient-oriented care. We look at the whole patient. We don't just take the history and examination. We don't just do the echo. We put them all together. The comprehensive assessment then leads to prompt and appropriate decision-making. You get great follow-up of these patients, and it paves the way for advanced physiologist practice with valve clinics, advanced assessment of heart failure patients and follow-up, etc., etc. So much better clinical practice overall. Thank you.
Just a reminder that you can put your questions onto Slido, or you could take the opportunity now to ask Dr. Siva anything that's burning. Have you got any questions?
Can I ask a question?
Yeah.
How many of you are clinical scientists? And how many of you own a stethoscope that you use every day? Excellent. So honestly, I can't stress it enough. You're in such a perfect position to be really good at this because you see all these patients with pathology all the time.
I think it's also the point you make about, the patient is not just a heart.
No.
The patient is a whole person. and the rest of the person impacts their presentation.
And also, you've got a long time. You've got, hopefully, at least a 40-minute slot when you perform an echo to actually be chatting away and asking questions and checking them over while you're actually scanning. So you're in a quite, believe it or not, a luxurious position. But I would say this only gets easy if you read about it and learn the sequence of examination and what murmurs are heard when. And the only way you can do that is actually just sit and learn it. And then put that learning into practice every day, and that way it's hardwired. A bit like what you do with a transthoracic, where you learn this massive data set, which is way harder than learning this, and you use that every single day. It's the same principle. If you just find a good book, learn a good comprehensive examination, and then just bear it in mind every day. So if you see your aortic stenosis, you go, oh, okay, what do I remember about that? Yes, pulse pressure might be narrow, let's check it out. Might be slow rising pulse, check it out. Ejection systolic murmur heard loudest at the second right intercostal space, check it out. Radiates to the carotids. I didn't mention that because I didn't want to overload you. All of that stuff you can do in moments, and it will reinforce your memory.
Thank you very much.
Thanks.
Okay, I'd just like to introduce our next speaker, who is Keith Pearce, who a few of you might already know. So Keith is the lead consultant cardiac scientist at Manchester Foundation Trust and the immediate past president of the BSE. And he's going to talk to us this afternoon about the patient presenting with chest pain.
Thanks very much. I have to reiterate the point that Anjana just said, which is around, or Emma actually said it, that the echo is not just about looking at somebody's heart. You've got to look at the complete patient picture. And Anjana's been through very nicely some of the aspects of clinical examination and how important they are that we probably don't practice all day, every day. And I understood this to be the training route of this room. Is that correct? Yeah? There's lots of people in here who know a lot more about echo than me. I can see one of them sat there, and over there, and over here. So they're in the wrong room and need to go somewhere else. So I was given a very poor brief that just said chest pain. That's all I got, which was kind of like when I rung Dan and said, what do you mean chest pain? And he was like, oh, just chest pain. So I haven't covered the examination aspects because you've already heard that and it'd be very boring. But chest pain as a symptom, to me, is a pretty boring subject, isn't it, to talk about in echo. And when we actually look at the new clinical triage guidance, chest pain is actually not an appropriate indication for an echo. It isn't in there. There needs to be more that's around it. So I'm going to show two cases. I'm going to keep it very simple and hopefully the images will move. You probably know what one of them is. You've probably never seen the other one, but we'll see. We'll see what happens. So this is our patient. This is Mrs. Manchester. And she's a 54-year-old lady who presented to A&E with some chest pain. And this was her ECG, so I'll let you all ponder the ECG for a moment. I'm not going to pick on anyone in particular. Dave? No, I won't. But this is essentially normal, plumb normal. Come to A&E, you'll see this all the time in your own departments. If you look a bit more into her, and remember when you're seeing patients for an echo, I like to have a look at what's gone on in their file and their notes and their presentation. So there's nothing acute on her ECG with a normal blood pressure, a normal sinus rhythm, around about 65 beats per minute. Her bloods were done and they showed a normal level of troponin, despite the admission with chest pain. Her EGFR was good, her hemoglobin is normal, creatinine was fine, height, weight, blood pressure, SATs, everything normal. Normal auscultation, normal lung sounds. So she's sat in our A&E department. There's a little bit more of a history taken from her, so we look at her risk factors. So an ex-smoker, 15 years since, nothing else to report. No diabetes, no CKD, no palpitations, none of those things that Anjana's just gone through that you can examine and you can look for. Medication, she takes nothing. And the only snippet in any of her history is a bit of a family history of ischemic heart disease in a father in her 70s, so not premature ischemic heart disease. So, clinical history is taken, so previously well, she noticed this central chest pain that felt sharp last night. Phone 111, advised an A&E attendance. Sent for an ambulance, waited 65 minutes, and then her husband decided to drive her in because he didn't want to wait anymore. Pain had built up through the afternoon, up into an intense pain which lasted about 5 minutes while she was sat down, and then she sat and it eased off. She feels much better for being in hospital, which often patients do because they feel safe and they feel as though somebody's doing something. And she reports a similar episode about 4 weeks ago, but again, no associated other symptoms with this. And the A&E plans, I'm sure you'll see in many of your hospitals, is that this is nothing acute, there's nil acute, the troponin is normal. We will discharge her out and refer her directly into the rapid access chest pain clinic. Now in our hospital, we have a system set up for a virtual ward. And the virtual ward is basically somewhere that's been referred out to the chest pain clinic. And what it means for us is that we've developed the role of a consultant scientist who will look at the patients who've attended A&E for chest pain troponin negative. So most of the patients who go out the door will end up back to primary care or directly into rapid access chest pain into whichever service. We have a nurse-led service for our chest pain clinic. But in this case, for A&E attendances, we've developed the role of the consultant scientist who will pick up from that virtual ward. So he doesn't have to be there every night, and it's Professor Stout, who you'll see walking around the BSE today over the next couple of days. And he will review these referrals. So what he will do is he will contact the patient, he will go through the symptoms again with them, usually within 24, 48 hours of that discharge, bearing in mind Martin doesn't like to work on a Saturday or a Sunday. He doesn't like to work on a Monday to a Friday either, but he does do it occasionally. And after his consultation over the phone with this particular patient, he reaffirmed that the admission details and the original symptoms have settled down, but she does report a background low-level discomfort, something not quite right. Non-exertional, but notices it just sometimes. So he chatted to her and he decided, you know what, we're going to bring her in anyhow at some point and we'll set her up through the rapid access chest pain clinic And for this type of patient, we often use functional imaging and access to exercise stress echo. And in her case, she was offered an appointment within 2 weeks. And the reason we do that is because as a consultant scientist, you can have the call with that patient, you can go for everything, and then you can book her into your list. So it's our list that we run with the nurses, with overarching clinical governance that you've heard off James this morning talking about stress-led services for physiologists. So it's dependent on our availability, and if he feels, you know what, this is a little bit more suspicious, he might bring her in next week, or if he feels I can just leave it a little bit longer, he'll leave it 2 or 3 weeks. And it's still quicker than getting into CT at the moment in our trust on the basis of a CT wait about 12 weeks. And when you're running your own particular list, you can pull these patients in. So she attends for her diagnostic clinic appointment, as we call it. So she comes along to clinic. And when she comes to clinic, she's reporting to us that she's had more chest pain this morning. So she's actually a director she's an HR director in a big electrical company who was given a lecture to an audience like this. I'm not going to have chest pain, but an audience like this where she's talking about the crisis, the cost of living to the people in the electricity industry, and whilst they're putting all their prices up, knowing that tomorrow she has to go into a formal consultation to basically dismiss 50 of these people in the audience. So she's in a very stressful situation. She's delivering the lecture, she feels some more central chest discomfort, she felt it was sharp but a little bit different to previous attendance, so we do her ECG, obviously. She's come to clinic, we're doing ECG. This is her ECG as she comes in to the clinic. So I'm sure you all know much more about ECG than I do. What we know, in addition to her ECG, is that we did a troponin. Have a quick look, because you can get it pretty quick if you ask for it. 450. So elevated. You can see that there's some anterolateral ST elevation. There's some T-wave inversion, certainly from V2 to V6. Some suggestion of ST elevation, T-wave inversion here, ST elevation in lead 2, just here, only small amounts. And the conclusion was, this is probably inferior, anterior, lateral dynamic ECG changes. So the patient's going to go to the cath lab. Okay, pretty sensible approach to things. That's what you're going to do with the troponin rise. This is to just remind me of the areas on the ECG, inferior, septum, anterior, lateral, just in case I forgot them, but I managed to get through them. So this was her angiogram. This is the right coronary. Can you dim the lights here, possibly? Can we do that? Do you think, just so people can see things a bit clearer? Beautiful, thank you. Right coronary, nice, patent, good lumen, beautiful flow through. Left coronary catheter into her LAD and her circumflex. Beautifully normal coronaries. Okay, so significant ECG changes, significant troponin, normal coronaries with this ECG. So then what do? Like you do in any good hospital, you do an echo. So the important thing is, do we think those changes are related in normal coronaries? Are they seen in the normal coronary artery system? So this is her echocardiogram. And you have to forgive me because this is one of Martin's, that's why it looks shocking. But never mind. So let's just have a look. So here is a 4-chamber view. As you can see that the aortic valve is not in, so we're representing the inferior septum right round to the apex down the lateral wall. And you can see basal preservation occurs here, but there's pretty much a ballooning of that apex with no motion in those areas. This is a 5-chamber view, so the anterior aortic valve is in situ, and therefore we've got some more of the anterior septum around here, and this phogogram of the lateral wall is in there as well. This is her 2-chamber view, so again you can see quite nicely, so mid to apical anterior wall with inferior involvement, infralateral involvement down to the inferior apex here, and again the same concepts of the anterior septum with the posterior wall. So what does it mean to us as scientists or as clinicians or as anybody? I use this diagram a lot in my own department. It's stuck on the wall. I'm very proud to say I drew it, which was good. But it overlies a 17-segment model with the probable areas where your coronary artery nomenclature should go. So if you look at this patient that we've just seen, we've just said that there is a mid-anteroseptal, an infraseptal, and apical septal region abnormality, which is in these regions here, which is 8, 9, and 14. And that relates to the LAD. Okay, we've also said that there is some infralateral problems going on in the mid, number 10, and in the 15. So that's right coronary artery usually. I mean, she's got big left dominant, and she's got a right dominant system actually, because the PDA came off the right, but never mind. And also we've got abnormalities out on this side as well. So that would suggest 3-vessel disease, wouldn't it? The ECG changes suggest 3-vessel disease. This fits into this and probably relates to about 10 out of 17 segments. And then if you actually took another piece that we have on the wall, which has been published by other people, but again, it's the same thing, it just hasn't got the coronary arteries on it. But it shows me the same things, and it gives me a reminder that the infraseptum, anteroseptum, can often be a combination of the right coronary or the left coronary, the LAD. It's not always one or the other. There is crossover in those regions. And you get these areas around this side where it might be circumflex or it might be LAD. So when you overlay them onto this diagram, we're looking at 3-vessel disease. That's what I'm getting at. That's what the ECG shows. That's what the echo shows. But the coronary angiogram does not show that. So, patient symptoms improve. A couple of days later, post-procedure, pre-discharge ECG, all settled down, returns to normal, patient goes home. Prior to going home, we arranged for her to have a CMR. I know this is an echo meeting, but everybody shows CMR pictures these days. And you'll notice that there is no Q wave development on this ECG either. Yeah, it's important. So this is her cardiac MR. I am not an expert in MR, but I know that's a 4-chamber, and I know that's a 2-chamber, and I know this is a short-axis stat that we can all do on our echo machines now with 3D capability. But you will see that there is basal preservation with mid to apical issues there, mid to apical here, and if you go from the top left, which is the high base, as you come down through each of these, you'll see there's complete virtual akinesia as you get down towards the apex. Okay? So you all know what the condition is, yeah? Everybody knows it. And if you do know it, you're in the wrong room, because you should have gone to the other one. So, normal coronaries, patient with these types of MR is the typical diagnosis of Takotsubo syndrome. And the outpatient MR was planned in 3 months to just evaluate the myocardial disease and to support the working diagnosis. So a discharge diagnosis was Takotsubo cardiomyopathy or Takotsubo syndrome or broken heart syndrome, whichever it is that you want to call it. And you've seen, you know what normal heart is. The Japanese octopus trap is this concept of Takotsubo. But it's being mindful as well that we've all seen, or some of us have seen, the different types. So this is the typical Takotsubo where you get basal preservation with mid to apical ballooning. You can get the inverse of that or the reverse of that, where you get basal ballooning with normal mid to apical contraction. You've also got the mid-ventricular type where it just affects the middle segments. And you've also got localized because it can be regional and can throw you out when you look at regional wall motion abnormality in Takotsubo. So that's a very simple case that shows all of that. This is a 3 months follow-up echo. So normal ventricle here, basal and mid portions working well. Mid cavity, nice contraction. Apex, come on, it's going to work. I might have to press it. Yeah, there you go, it works. So again, mid and basal segments. A suggestion potentially, if you look close enough, there may be a small area in that apex that's not quite recovered or responded. Return to normal. Anterior wall's beautiful, infralateral wall beautiful, inferior wall and infralateral and septum. And then we repeated her CMR, which again fits nicely with the fact there's a slight defect there in the apex, which is perfectly seen on the echo, which says, why the hell do we need another CMR? But we don't worry about money anymore. We just scan everybody with everything. But you can see it's all returned to normal, which is a very nice case, but just don't be thrown out by those ECGs. And that's why it's important to treat the whole patient and not just one piece of the jigsaw. I've got 5 more minutes, haven't I? Okay, chest pain, case 2. So this is not a binary type of program. This is our schematic of our department. This is Keith's echo room, and these are the other 5 echo rooms. And the reason this is my echo room is because it's the furthest away from there, where I sit my patients. Now, most patients come, and they'll come and check in at the main reception desk in the diagnostics unit, and they'll sit here. And these people who work in these rooms sit in a nice little hub, because we look after them and we make sure they can have a cup of coffee, and it's very nice. And then they have these other things called echo support workers, yeah? And they go out and they get the patient, and bring the patient in, and do the height, the weight, the blood pressure, and they put them on the bed, and Wendy goes in and lords it up, and does her bit, and then goes out and does the report. It's great. That's how you seamless service. Keith tells his patients to sit in the main outpatients here, and I purposely make them sit down here at this bottom right. It's kind of like a creature of habit. It's just something I've always done, but I sit them bottom right. And the reason for that is because my echo starts when I start to move towards the patient, not when I walk in the room here. So I walk to the clinic, which is about 35 yards, something like that, not that far. I walk to the clinic, I simply come down the corridor, my patients are sat here, so I don't know which patient I'm seeing, but I always tell the receptionist to sit my patient there. She thinks I'm a bit of an arse, really, but it's not, it's because I like it. Because when I walk in, I will shout, Mrs. Airport. This is this patient, Mrs. Airport. Manchester Airport. Mrs. Airport. Now I know Mrs. Airport is going to be sat down here somewhere. So the moment I shout her, what I'm able to do is have a quick look at her ankles if she's not wearing boots because it's winter. So it's kind of like you can work out whether there's any obvious peripheral edema going on early. And I watch her get up because I like to see how they get up and are they frail. Do they need support? Do they walk slowly? I stand here and make them walk to me, and it's not because I'm mean or horrible. It's just because I want to see what they do. We're not allowed to shake hands with patients anymore, are we? But that was really useful to just feel, are they cold, have they got pallor? You could have a sneaky look at the fingers, potentially for club fingers, all those bits and pieces. So your echo should start when you go to the waiting room. And I'm all for echo support workers. I think they do a great job, absolutely. Streamline the service. But for me, in the clinical examination, it starts then. So it starts the moment I go into that waiting room. So this is her, Mrs. Airport, is a 36-year-old female who has come again for chest pain. That thing that we're meant to be triaging out that we don't do anymore. But she's come again for chest pain. So I go around and I collect her from the waiting room. And the initial impression I get from her is she's able to get up. She's unaided. She walks with no support. She can walk all the way to the echo room without stopping. She's got no breathlessness. She can talk when she walks. Anjana just spoke about that, about being able to talk when you're walking along. In the echo room, do her vitals, blood pressure's fine, SATs is good, pulse is not too bad. And when I'm chatting to her, we haven't even stuck a probe on it yet, I just talk to her about her previous history. And after short questioning, she says to me, oh, you know, I'm really good at the minute, but I've had a terrible situation a few months ago. And she opens up about an excessive use of alcohol and misuse of all these bits and pieces. She had a bit of a psychotic episode and doesn't really know what happened to her during this period of time. But she states, I feel much better now. I'm much more improved. I'm much more compliant with my meds. But I've really still got this chest pain. So, after chatting, brief clinical examination, no peripheral edema, normal heart sounds, no obvious visible scars on the chest, couldn't see anything, cardiac devices not in situ, she's able to walk, she's able to do all this. What on earth is her chest pain? So this is her echo. Again, I think these are down probably enough. So you've got two pictures, both parasternal long axis. What do you see? Anything? Who's going to be brave enough to put their head above the parapet? A trainee, maybe? Nobody? Okay. Parasternal long axis looks to me like it's normal function. I'm not really too worried. You can tell already that the valves are pretty mobile. There's no colour, there's not much else there. But there is a slight bright echogenic structure right there in the middle of that cavity. Can you see it? Does anybody think that's unusual? And if something has got a reverberation of that stature, that's got to be something, hasn't it? Because it's very bright. It's not a typical LV band. It's not an implantable lead, because I've already said she hasn't got devices in, and why would it be flapping around in the middle of the left ventricle? But there's a bright structure. So we go around to the parasternal views. You get a little bit of a short axis at the aortic valve level and a bit at the mid-cavity level. And again, nothing major, but there is a linear little structure just there. And I'm thinking, there's got to be a better view of this. So you go off-piste a bit, don't you? A little bit off axis, and you go and have a look at something else. So this is a slightly different rib space in a slightly different place, and it's a parasternal short axis. And this is a 4-chamber view, and this is a 2-chamber view. And now you can see there is a clear, very bright echo-reflective structure here, here, transversing the right ventricle into the left ventricle, and here. Any ideas? I told you wouldn't have seen this one before. Pneumothorax. Good guess, but no, it wasn't. But good guess. So, what transpires with this lady, because this is why you've got to treat the patient. When you then open up her electronic patient record, and you go delving and you go looking, because in our echo rooms, we just do the echo with what's on the sheet in front of you, yeah? But you pull up that electronic record, and she failed to tell me that she'd had an admission recently, a few months ago, where the general surgeons brought her in and put her onto ICU. Because during this psychotic episode a while ago, she conflicted self-harm by inserting seven sewing needles into her body. And the general surgeon took 5 of them out. 2 out the liver, 1 out of somewhere else, 1 out somewhere else. But the cardiac people looked and said, the 2 in the heart, we can't touch them. You've got to leave them alone. And this is what they are. They are linear, bright structures of sewing needles, self-inflicted through the sternum, X about 7-8 centimetres long, pushed into her own body. So it's a very unusual presentation of chest pain, but it proves a point to me that it is all about, as we've already said, being more than just the echocardiogram. Unfortunately, she passed away about 2 years later, not from that, and they were still in situ at the time, so it was the right decision to leave them where they were. I'm going to stop there. I'm happy to take questions. There won't be many, I hope. But,
Thanks, Keith. 2 really interesting cases. Has anyone got any questions for Keith?
On the first case, the Takasubo, how do you treat that patient? Is it just reassurance and monitoring?
No, see, now you're asking clinical questions on treatment. But we didn't do anything for her. I think it's a syndrome that does resolve itself, but you do have to potentially look at, is there any myocardial disease afterwards? She went home and did very, very well after that, and as you've seen, has had the MR scan done. You'll just do risk factor profiling and all those bits and pieces. It's quite rare, Takotsubo, but it can happen, again, in the same person. And that's something to be mindful of, and she's got to be mindful of that in her own risk factors. But I put it down to the stressful situation she was in, and that's why it's referred to, isn't it, as broken hearts, and you get bad news, and people develop these things. That's what you get, but it's not an underlying coronary disease problem. Maybe Tom will tell us a bit more about it when he comes up. Fingers crossed, and she'll be all right. Yeah, I'm sure she will. Okay, thank you.
Thank you very much.
That's a dirty glance cleaner.
That's good.
So I'm pleased to introduce our last speaker, but certainly not least. Dr. Tom Ingram is a consultant cardiologist at Wolverhampton, and Tom's been involved in the BSE workforce surveys and in the Leadership Academy. He's been asked to talk to us about the patient presenting with palpitations.
Fab. Thank you very much. So, it's absolutely wonderful to be asked to give a talk here. I think I was talking to Anjana earlier when we're both cardiologists, and we were very much admitting it is total self-interest, this, because, we both need more hours in the day to drink coffee. we can upskill the workforce to do the bits of our job, which means we've got more time to drink coffee, then it's win-win. So with that in mind, I'm going to move on to the third of the... Oh, thank you. I'm going to move on to the third of the classic cardiology symptoms, as we like to call them, the holy triad, palpitations. And I've taken an approach to this talk which is very much around the symptoms that the patient is going to give you, and you'll be there scanning them perhaps, but they'll be asking you symptoms, you'll be getting symptoms from them, and it's just to allow you to kind of re-stratify how worried you are. Because one of the real kickers about being a cardiologist is that the symptoms the patient gives you rarely represents the severity of the underlying problem. And it's really annoying, and I say to all my medical students, or even patients if they'll listen, it's not like if you break a leg and you go, yeah, it's that one, it really hurts, and it's obvious it's broken. You know, chest pain, palpitations, there can be clues in there to help you, but more often than not, they're only a part of the whole process, and we have to bring them together into our diagnostic synthesis journey. So, let's think about palpitations that are coming through, and I'm going to drill down what palpitations means, because the first lesson is it means different things to different people, and do not use the term palpitations without drilling down what the patient means with that, and we'll go through the classic histories there. But when you're listening to a story of palpitations, you are a detective. So you're not there just trying to faithfully reproduce the story they're telling you back on a piece of paper. You've actually got to go in, and this is what you're trying to decide. Have they got palpitations because they've got an excitable heart? You know, if you go for a run, you get palpitations. That is normal, and it is an appropriate physiological response. If you're anemic, if you're hyperthyroid, you get palpitations. That is not heart disease. The heart is reacting, and accordingly, they will have, more often than not, a structurally normal heart. And that's opposed to when the palpitations might represent a marker of underlying structural heart disease. And if we go down that journey a bit more, we can break it down further. And with our echo, which is really going to be the weapon of choice, the tool of choice with these people, we're looking for some key features. We're looking for cavity dilatation, because a dilated cavity complains. And if it's an atria, you get an atrial arrhythmia. If it's a ventricle, you get a ventricular arrhythmia. And there's problems which go with each of those, but I think you all know which one of those two you'd rather have. And you've got to think as well, if it's not cavity dilatation, the other cause of that structural heart disease will be scar and fibrosis. And that could be surgical, having had previous surgery, or it could be a disease process itself. So, let's talk a bit about the first group of people. And we're going to talk about ectopic heartbeats. So common. And the advent of those lovely Apple Watches, Fitbit watches, etc. is one of, you know, my favourite things. I'll probably put my kids through university on the back of it, but that's a different story. But it has just made these things so much more prevalent, and a pseudo-understanding of it, if you like, so much more prevalent out there. And you need to have some tools to cope with it. So here we've got, I'll move this round. We've got our ectopic heartbeats, and they are supraventricular ectopics, so they match the QRS appearance of a sinus beat. And there is this classic pattern to them, which I'll go through in the next slide, and we'll talk about the symptoms you get with it. Because what ectopic heartbeat sensation is it's the beat-to-beat variation in left ventricular stroke volume that the patient is describing to you. So by that, what I mean is, let's look at our trace here. You're going to work. You are going to work. Beautiful. So if we just take these 3 beats, the ones on the left, I'm going to put this down because I can't do it like this. I haven't got enough hands. Right, I'll do it from here and you won't be able to see my amazing belt, but never mind. So you don't need to see that. It was one for my jeans yesterday. I didn't have a smart pair with me. So we've got our 3 beats here, and there's the ectopic beat in the middle, and we've got our 3 beats here, which are sinus. And that time period between those is identical. And that's key here, because what we've got is we've got a difference in the period of diastole between those beats. And so on the right, you've got an equal period of diastole for all of those beats. So you will get a regular stroke volume that is matched along those beats. On the left, because you've got this beat here has had its diastole beforehand, so you'll get your stroke volume. You then have a truncated period of diastole before the supraventricular early beat comes in. So that heartbeat is not associated with generation of a pulse, but the body's wise to this. It's got your back. And so what it's done is it waits a compensatory longer period of time, giving you a longer period of diastole, and then a thump. Okay. And the thing you must remember here, and everyone in this room who scans will know this already, because they'll know when the request card says ectopic heartbeat, they'll know it's going to be a nice, easy, normal scan, more often than not. And that's because in order for you to get symptoms, you have to have a good ventricle. So, if we think about it, I'm going to go through these, yeah. So, the symptoms which you get are these kind of flutters, bumps, thumps in the chest. They're isolated, they're short-lived, but you can have clusters of them, representing those beats. And you need to have a normal ventricle to allow you to get that beat-to-beat variation in stroke volume. It needs to be a nice, compliant, flexible ventricle that can add in that extra period of diastole and mount a stroke volume with it compared to the ectopic beat. Now, I've had a bit of fun here, and I strongly recommend if any of you are writing talks in the near future, one of the best things to do is get on Google Images, because it really helps you. And I wanted to get some images expressing patients. And so you type in patient symptoms. And I like this one here because it kind of sums up about ectopic heartbeats. We sent the rookie down to take the history. We sent the young man. And he's looking quite happy. He's quite confident. There's not going to be a major problem here, actually, with this patient. I'm pretty comfortable with this one. I've got this. And so, as I was saying here, on the left, you've got your structurally normal heart, and that will give you symptoms with ectopic heartbeats. Whereas on the right, with your left ventricular dysfunction, that longer period of diastole will not be associated with an increase in stroke volume because it's so reliant on the fact that you've got poor systolic function, which trumps it. Okay. So, that is your ectopic heartbeat sensation. If you have a patient with it, you can often be confident, or you think they're unlikely to have underlying structural heart disease. Now, don't conflate something there. Frequent ventricular ectopy that you might pick up on ambulatory ECG monitoring can be associated with structural heart disease. I'm just saying they may not necessarily present with the symptoms of palpitations with it. Okay? Bear that in mind. And just to show that we practice what we preach at the BSE, we've very much attached that 5 minutes worth of clinical reasoning into our clinical triage guidance, and we put down as a not indicated various situations of palpitations like I'm describing there with ectopic heartbeat sensation, low burden of ventricular ectopy, or someone experienced, a clinician who's happy that there's unlikely to be structural heart disease underneath, no murmurs, normal 12-lead ECG. And particularly, I see Andy's in the audience here. This is something we're really keen to also pass out to assist our primary care colleagues as well, because I think it could be a really useful tool. So, we've talked a bit about ectopic heartbeat sensation. I'm now going to move on to talk a bit about atrial arrhythmias. I don't understand these ECGs. I just put them there to try and look clever. I'm not an EP doctor, so I'm not going to go through the actual ECGs in that much detail. I'm just going to relate it back to that question I gave you a minute ago, which is, it's not about the palpitations, it's about, do I think that represents underlying structural heart disease? Because that is where the echo is adding value. And so this example here of a narrow complex tachycardia, a supraventricular tachycardia, and this case is a AV node re-entry tachycardia, you would be most of the time feeling that this would not be associated with underlying structural heart disease. Now, clearly it can be if they've got other symptoms, dyspnea, chest pain, etc. But if their sole symptom is presenting with their tachycardia related to this kind of rhythm, it is rarely associated with structural heart disease. But let's move on to some other examples, because it would be pretty boring for me just to stand here and say, your job's pointless in these patients, because it really isn't. There's a lot we can do. And so this is a case I had on call whenever that was, middle of the pandemic. We tend to like to talk about that. It's hard in our mind. So this was a 38-year-old lady, teacher, who presented with a 3-day history of persistent palpitations. And the absolute key for this lady was the fact that she said, my heart rate has been at this level, which was about 140 beats a minute, so not really pocketing into our atrial flutter SVT kind of range. It's been at that rate constantly. And we had her in a monitor in A&E, and it just stayed at that level. Because remember, a sinus tachycardia, which the ECG will tell us there's a sinus tachycardia, varies. So it varies, maybe not over the 10 seconds of your 12-lead ECG, but it varies over sort of a few minutes up and down. It can stay fast, but it varies between 120, 140, whatever. And I've just given you the clue here. She had a big scar on her chest, and she had a Fontan circulation. She was a very bright lady, teacher, getting on with her life as a lot of the congenital heart disease patients are. And the medical registrar, very sensibly, having been urged by the A&E colleagues to give this lady amiodarone, decided that was not a great idea because he'd been to a talk once by a cardiologist that said in these patients giving them vasodilator medication can go very badly, which is true. And the treatment for this lady for her sinus tachycardia, which is not a sinus tachycardia, it is actually a supraventricular atypical atrial flutter around her atriotomy scar. The treatment is electricity, and I'll show you the surgery in a second. But if you don't believe me, that's her having had DC cardioversion quite safely in theatres, and we got her heart back to sinus rhythm, and it shows you the abnormalities to the T waves consistent with her single ventricular circulation. Now, the point of this talk is just to mention that although these supraventricular tachycardias may well relate to pathologies we're going to talk about in a second to do with atrial changes in volume and pressure load, this is an example here of how it relates to the surgical incision which was used for her operation many years ago to basically tie off half of the heart, if you like, because part of it wasn't well developed, and give her this single ventricular circulation. And there's some lovely cases that my congenital colleagues show whereby in years gone by before surgeons knew any better, they used to open the heart via a ventricular incision because it would be easier, but that then led to patients years later having a scar in their ventricle and their arrhythmias would be ventricular and fatal. So now we do atrial incisions across the board. The surgeons have to fiddle a bit more, but it leaves you in a much safer position because the lady I've just shown you can have gone for her, can go for electrophysiology treatment to ablate the source of her tachycardia, but she isn't in a dangerous position. So that's an extreme example there, not as extreme as Keith's, of people with knives in their chest or whatever it was walking into clinic. That doesn't happen very often. But that's a nice example just to illustrate a rarer cause of the atrial arrhythmias. But let's look at a commoner atrial arrhythmia here, atrial fibrillation, which is basically what's in the post for all of us if we live long enough, really. It's that common, isn't it? And it relates to just the multiple ectopic foci throughout the atria, the chaotic rhythm. And in some cases, this will be because of a single focus in the pulmonary veins, which then propagates through to cause the more chaotic atrial arrhythmia, and that is associated with an excitable, structurally normal heart. But more often than not, atrial fibrillation is actually a marker of underlying structural heart disease. And we've got this marvellous tool with atrial fibrillation to decide whether someone needs anticoagulation. And when I'm talking to medical students, we go through it. It's called CHADS2 VASC. And it actually, if you break it down, is just a list of risk factors for structural heart disease. So congestive heart failure, hypertension, age, diabetes, etc., etc. They are drivers of underlying structural heart disease. And the structural heart disease they're most likely driving is this one on the left, which is the one that anyone who scans will spend a good 50% of their day scanning, which is heart failure with a preserved ejection fraction. It's stiffness to left ventricular filling, usually in the setting of long-standing hypertension, and the body has to compensate to maintain your stroke volume by increasing the left atrial size, because the left atria has no muscle. So in order for it to fight against that poorly compliant left ventricle and push the blood in, all it can do is get bigger and bigger. And as it gets bigger and bigger, it's like an elastic band. It goes into your atrial fibrillation. And so there is some nice guidance out there which suggests that if you come across new atrial fibrillation, it on its own is an indication for a transthoracic echocardiogram, because your yield of picking up pathology is quite high in this group. And then on the right, I've just got an example. It doesn't have to be HFpEF, though that is 50–80% of the list in these cases. But you might get a weird and wonderful case like the one here, which is an enlarged right atrium as a result of an atrial septal defect. And that's causing more of a volume overload rather than pressure overload of the atria, but will also tickle the atria and cause you to have potential atrial fibrillation. So let's bring that back to our patient. And again, I've been on Google Images and I put down slightly more worried presentation with palpitations, patient talking to doctor. And it came up here. We've got the slightly more serious doctor. We haven't sent down the rookie. He's looking a bit more serious, but he's just come down on his own. And the man, he's looking a bit more grave because he's a bit more worried about his symptoms. And that reflects the fact that there is a bit more of a yield of structural heart disease in these people, but they're generally safe, and we'll talk about that in a second. And the thing about them, again, is they may have no symptoms. So if you go into atrial fibrillation, you lose about 30% of your cardiac output. But if you're not doing much day to day, you can probably cope with that, actually. And it's the fast heart rate which gives you the symptoms. And that can be all the time, or it can be in bouts if it's paroxysmal. And you tend to find with patients, I use this term where it's disconcerting, but it's not disabling. And that's because this kind of palpitations, which are very all-consuming, they don't feel like doing a lot while they've got them, if they're too tachycardic, they're rarely associated with underlying hemodynamic instability on their own. There may be a problem like that Fontan lady in the background where you could get hemodynamic instability, but the actual tachycardia itself is rarely driving underlying hemodynamic instability. And the reason for that is that we have evolved through, before our species, when the heart was in frogs or whatever. I'm not very good at describing the evolution of it. But one thing is, we've evolved so that atrial arrhythmias do not cause sudden cardiac death. Because if you think about it, atrial arrhythmias are going to be quite common because as you get older, you get stiffer ventricles, and those atria are going to have to enlarge because that's all they can do. They haven't got muscle, as I said before. They're going to have to enlarge, so they're quite common. And so what we've got is this electrical isolation at all points between the atria and the ventricle, apart from the AV node, and the AV node has this phenomena called decremental conduction. It's why when you go to the gym, the treadmill has these kind of ranges of heart rate, and it goes down as you get older. That's not because it's dangerous to push your heart above that level as you get older. It's just because the heart has evolved so that someone in their 80s is not able to pump their heart to as fast a rate as someone in their 20s, because we know the body has balanced itself to know what a dangerous heart rate would be. Okay. Now, there's one exception to that, which I'll just put here at the bottom, which is when you've got an accessory pathway with a Wolff-Parkinson-White. And that's a different conversation, but that is when an atrial arrhythmia can be associated with nasty hemodynamic instability symptoms, syncope. And they have their own journey to go on, which involves seeing a cardiologist very much, seeing an electrophysiology cardiologist. Okay, last bit. We're upping the ante now. We're moving on to ventricular arrhythmias. So this ECG here I quite like because it's got the classic abnormal upward projection of the QRS pattern in AVR. And when we look at our 12-lead ECG, we recognise that this means there'll be an ectopic focus somewhere towards the apex, and it will be activating the wrong way round. So it's normally lead 2 which is positive, but if AVR is positive, that is not compatible with sinus rhythm. That has, or with a supraventricular rhythm, that has to be a rhythm originating within the ventricle. So that's one of the ways to find out if it's a ventricular tachycardia on an ECG. This isn't an ECG talk. I just put that in to sound clever. And it marries into the case which I'm going to show you here, which is someone who's got severe LV impairment relating to a previous anterior myocardial infarction. As Keith says, you have to put an MR in because otherwise they get upset, don't they? And I fully agree. I cannot understand why you did an MR for the second time on that lady in the last one. But I'm pleased you've got so much money, Keith. Good for you. Anyhow, we're not where I work. So this is our severe LV impairment, akinesia towards the apex, and we've got our scar here. So that is the nidus, the source of the ventricular arrhythmia. It's not the scar itself, it's the periischemic tissue around the scar which causes it, and that is a potential cause you could pick up on echo. As I said earlier, it could be scarring or it could be cavity dilatation. And here's another example of a large atrial septal defect. And in this situation, you've got dilatation pretty markedly of the right ventricle compared to the left ventricle, and we can see the shunt running there. Low velocity, high volume, because it's a big hole, and that is the hallmark of an atrial septal defect, so it rarely gives you a murmur, unless you've got a flow murmur across the pulmonary valve. But you can appreciate how that right ventricle can start to get a bit cross because it's being stretched out, and those myocytes might just say, I'm not waiting for the sinus beat, I'm just going to fire off myself. And then this would be a case as one I had a couple of weeks ago on the ward of an elderly gentleman presenting with severe aortic stenosis, but presenting towards the end stage of the disease because he unfortunately also has a dilated, failing left ventricular cavity. And importantly in these people, it may be the aortic stenosis which is driving this, and it would get better with relief of the obstruction, but you also need to have knowledge of their coronaries because it may be a concomitant myocardial infarction, like that case I showed of an anterior myocardial infarction causing it as well. So in this situation, you've got two separate reasons why you might present with your ventricular arrhythmia in that case. And so how's our patient going to be in this group? So I Googled very ill patient presenting with ventricular palpitations. And it came up with this here. And I mean, gosh, they got the boss out. They got the boss out, and he's got some team with him. They've all come down because they're worried. And he's looking very worried, this man. He's looking very worried. And he's right to. Because ventricular arrhythmia, you won't tend to get people presenting with palpitations. They may do. There may be an exercise trigger, but they may just occur without warning. And I don't think exercise is a massive precipitant in these people. They often just get it at any time. And it's not the palpitations they tend to get. It's the hemodynamic effect of the heart beating so quickly that it doesn't have time to fill with blood during diastole. And that hemodynamic collapse causes syncope or presyncope. And you'll only be seeing them because they have come back from it. So it will be a transient period of time, but that episode of syncope, rather than someone with simple vasovagal syncope, where there tends to be this very dramatic precursor symptoms, transient loss of consciousness, feeling groggy afterwards for a while. In this situation, it's a much more collapse any time, and if they come round, feel fine afterwards. Okay, so it's at odds again, the clinical history, with the severity of the underlying problem. But your friend in this group is also asking them about a recent deterioration in exercise capacity, previous cardiac history, all these other features that you're throwing into the mix to decide how unwell you think they are and what you think is going on. So, in summary, palpitations can be a marker of underlying structural heart disease, and therefore echo is an absolutely key test. However, you've got this conflict between the severity of symptoms and the presence of underlying pathology. And I would say, particularly if people have got simple ectopic heartbeat sensation, the scan will often be normal. Now, when you do find echo abnormalities, it often relates to cavity dilatation or the presence of myocardial scarring or fibrosis. And if that structural abnormality relates to a ventricle, that can present with red flag symptoms, which is when you really need to be pushing forward their care with great nurture to make sure they get through the system as quick as possible. Okay, thank you very much. I'm happy to take any questions.
Does anyone have any questions for Dr. Ingram? I'm aware it's the end of the day. I'm not going to add a question just because I'm the chair. I have some announcements. Thank you, Tom. That's great. So the organisation team would like me to remind you that now there is a drinks reception in the Britain reception, which was the main exhibition hall that you were in earlier. So if you'd like a free drink and to go and socialise with everyone, which we haven't been able to do for a while, and go and join people there. And Hattie Grant has also asked me to remind you that tomorrow, on your way in, to get your BSE points, you will be asked to scan. Okay, so you'll be asked to scan something on your way in. The reason for that is for your CPD points. Okay, so enjoy your evening. See you tomorrow. Thank you very much.